This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1. Questions. 1 to 12, you hear a doctor talking to a new patient called Emily Thompson. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hi, Emily. It's good to see you again. I've gone through your records, and I noticed that you were diagnosed with an autoimmune disorder about 3 months ago. Can you remind me what that was?
Yes, it's Crohn's disease, and it has definitely been a challenging condition to manage. The symptoms can be unpredictable, and there are days when it feels like a constant uphill battle. From dealing with flare-ups to making significant adjustments in my daily routine, it affects nearly every aspect of my life. Managing the pain, fatigue, and dietary restrictions can be overwhelming at times, and even though I'm on medication, it's still difficult to maintain a sense of normalcy. The unpredictability of the disease makes it even more challenging to plan ahead or feel fully in control of my health.
I'm sure. And last month, you had to be hospitalized, right? What happened?
Yes, I was in the hospital for about 5 days because of severe inflammation in my intestines. The pain was intense, and I could barely eat without experiencing terrible discomfort. The doctors monitored me closely during that time, and I was eventually prescribed a combination of steroids and anti-inflammatory medications to help manage the symptoms. These have been somewhat effective in controlling the inflammation, but I'm still navigating the challenges of finding the right balance in treatment. It's been tough, but the medications are helping to keep things under control for now.
That sounds difficult. Let's talk about your current symptoms. How's the abdominal pain now?
It's still quite difficult to manage, especially after meals. The cramping can become extremely intense, almost unbearable at times. It feels like my stomach is twisting in knots, and the pain comes in waves that leave me feeling drained and uncomfortable for hours. Even when I try to eat smaller portions or stick to a bland diet, the cramps often hit hard, making it a real challenge to maintain a normal eating routine. The discomfort lingers long after the meal, affecting not just my digestion, but my overall energy and mood.
Any other symptoms besides the pain?
Well, I often feel nauseous and vomit sometimes, and I'm always so tired I feel weak all the time, especially my muscles.
So fatigue and muscle weakness. That must be draining. What about your digestion? Any difficulty after eating?
Yes, especially after bigger meals. I feel bloated and uncomfortable, and it just doesn't sit right.
Okay. I know you mentioned before that your job involves long hours on your feet. You're still working full-time?
Yes, I work as a nurse, so I'm on my feet a lot.
That makes it tougher. For now, I'll recommend we stick to the plan and make sure you're following the anti-inflammatory diet we talked about to minimize the pain and inflammation.
I've been trying. What's next for the treatment?
I'm looking to get some blood work done, primarily to assess whether there's any ongoing inflammation or signs that the disease is progressing. I want to get a clearer picture of what's happening inside, especially since your symptoms haven't fully subsided. The results will help determine if the current treatment is actually making a difference. If the tests indicate that the inflammation is still present or worsening, we may have to explore other options, like immunosuppressive therapy, as the next step. It's a more aggressive approach, but if this current course of treatment doesn't show improvement, it might be the only way to manage the disease more effectively.
Oh, that sounds serious. Is there anything else I can do to manage the symptoms?
Yes, it's important that you avoid fatty foods because they can significantly aggravate your digestive issues. These types of foods tend to slow down the digestion process and put extra strain on your system, often leading to increased discomfort, bloating, or even more severe symptoms. Reducing your intake of fatty foods could potentially make a big difference in how you feel overall, helping to ease some of the digestive problems you've been experiencing. Making this change in your diet may not completely eliminate the symptoms, but it can play a crucial role in improving your condition and preventing further flare-ups.
Extract 2. Questions 13 to 24. You hear a cardiologist discussing a patient called Mark Robbins. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, Mr. Robbins. How have you been feeling since our last appointment?
Good morning, Doctor. I've been okay, but there are still a few things I'm concerned about.
Very well. Let us meticulously review the matter at hand. It appears, from what is discernible, that you have endured a persistent condition of hypertension, spanning a period exceeding a decade. Is that an accurate understanding?
Yes, that's right. It's been a long time, and I've been trying to manage it as best as I can.
I remember we also discussed that heart disease runs in your family. Has anyone else had recent issues?
Yes, unfortunately. Both my father and my uncle had heart attacks, so it's definitely a concern for me.
Comprehensible. You alluded to the observation of an increased prevalence of shortness of breath during physical exertion as of late. Could you elucidate the frequency with which such occurrences manifest?
It's more frequent these days. A few months ago, I was diagnosed with angina after I had some chest pains while jogging. That's what really made me come in.
I see. And we started you on medication after that, correct? You underwent angioplasty to open up those narrowed arteries. How did that go?
Yeah, the procedure went well, and I felt much better afterward. The chest pains are gone now.
It's heartening to learn. Moreover, we previously advised certain modifications to your daily habits, such as embracing a low-sodium dietary regime to ameliorate your blood pressure. Have you been adhering to this course of action?
I've been doing my best. It's tough, but I know it's important.
Great. Now, you mentioned some new symptoms. What's been going on?
Well, lately I've been waking up with headaches in the mornings, and sometimes I feel a bit off.
Additionally, if I recall correctly, you've encountered episodes of lightheadedness or dizziness when rising abruptly from a seated or reclined position. Is that correct? This sensation, often described as a momentary loss of equilibrium or faintness, typically occurs when transitioning too swiftly to an upright stance, doesn't it?
Yes, exactly. I get lightheaded for a few seconds, but then it passes.
That's definitely something that requires vigilant observation. In your most recent stress test, your cholesterol levels were elevated beyond the normal range, which could very well be a factor contributing to these symptoms you're experiencing. We'll need to keep a close watch on this, and if the situation persists or worsens, we may need to reassess and adjust your medication accordingly.
All right, doctor. On the topic of medications, if I'm not mistaken, you've recently prescribed something specifically aimed at regulating or stabilizing my heart rate, correct? I just want to confirm if that's part of the current treatment plan and understand how it fits into managing my overall condition.
Yes, that's right. It's important to keep it within a healthy range. How have you been feeling since you started the new prescription?
I've been doing fine, but I'm also monitoring my blood pressure regularly, like you suggested.
Perfect. Keep doing that. Is there anything else bothering you at the moment?
Well, I've noticed some palpitations at night. It's not every night, but enough that it's made me a little anxious.
We'll definitely keep an eye on that. I understand you're also worried about the side effects of some of the medications.
Yes, that's one of my main concerns. I know the medication is important, but I just want to be aware of any potential risks in the long run.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Now that we've explained how to use the inhaler, do you feel comfortable with the instructions?
I think so. I'll need to help him at first, right?
Yes, exactly. Over time, he'll learn to do it himself, but it's important to supervise for now.
My biggest worry is making sure he remembers to use it regularly. He's young, and sometimes he doesn't even notice when his breathing is getting worse.
I understand. We recommend starting a routine, perhaps tying it to his morning or bedtime activities, so it becomes a habit.
That makes sense. I'm also wondering, are there any side effects I should watch out for?
It's quite rare with this type of medication, but sometimes children might experience a dry throat or a slight tremor in their hands after using the inhaler.
Okay, so nothing too serious then. That's good to know.
One of our key priorities is improving communications between staff, patients, and patients' families. We recently introduced a scheme called Dear Doctor, which involves giving each patient a card where they can make a note of any questions or concerns that they themselves have. They can also talk to their families during visiting time or even on the phone and see if there's anything else they'd like to add. The cards are then collected and given to the doctor before the ward round. We're really pleased with the response. Patients used to say they only thought of the things they felt they needed to discuss when it was too late. So the cards give them a better chance to bring up whatever's on their minds. In fact, it's been so successful that we're going to roll it out on all wards in the hospital.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams. Groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas isn't quite clear within the evidence, but the work we're doing aims to address such issues while looking at the challenges of implementation and evaluation.
So, are you interested in trying a new way of treating your type 2 diabetes through diet? The diet would involve cutting your calorie intake down to 800 a day.
Oh, that's not many.
Well, it'd mean cutting out fat and sugar and just eating protein and vegetables, but the payoff could be that you'll be completely diabetes-free.
Well, it does sound like a healthy diet, and I guess I ought to have a go if there's a chance of beating the condition. I just hope it's worth the effort, though. I mean, there's no guarantee I won't still have diabetes at the end of it all, is there?
Well, this is a new treatment, but we wouldn't undertake it without some prospect of success.
Now, Mr. James, looking at the latest images of your eye, I'd say there are signs of improvement.
Well, I'm not completely cured, but there's less distortion in my vision. That's a huge relief. I could barely recognize people in the early stages. I'm still not confident about night driving, and I know I've lost color perception in the center of the affected eye. Everything's gray. I notice it when I close the other one.
Well, that's certainly what the images suggest, and what you describe is entirely to be expected. Despite the fact that your eye's recovered up to a point, there will be permanent damage to the retina. Instead of lying smoothly against the eye's inner surface, it'll stay a bit wrinkled, which would explain your symptoms.
At least my vision's clearer than it was. I'm grateful for that.
As you're aware, many of our outpatients struggle to take their prescribed hypertensive medication, so we've looked into the reasons for unintentional lack of compliance. We discovered that one of the key reasons for patients forgetting to take their tablets was because of the number of pills required. Reducing the amount prescribed isn't possible, of course, but something as simple as urine testing to monitor patients is proving an effective intervention. The results of our trials show that over 50% of patients undergoing urine testing became completely adherent to their drug regime as a result, which, of course, leads to better outcomes. This is an important breakthrough, given that previous studies showed limited benefits for high-risk patients from complex and costly alternatives aimed at reducing rates of stroke and heart disease.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear a microbiologist called Dr. Jane Finn giving a presentation about the overuse of antibiotics. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Jane Finn and I'm a microbiologist. I'm talking today about the overuse of antibiotics, or antimicrobials as they're often called, and the serious dangers this poses for the future. We're all familiar with the threat of a post-antibiotic era in medicine. But how did we get to this point? Well, in the decade up to 2010, we saw a staggering increase of 36% in antibiotic use worldwide. As more and more global citizens were able to access them, usually online, we saw uncontrolled consumption during that period. Although recent media stories suggest the general public has finally got the message that antibiotics should be used sparingly, there's still a hard core who want them prescribed for everything. Doctors are now better at resisting their demands, however, for example when the problem's viral rather than bacterial. This has improved things. For instance, there's been a fall recorded in the overall amount of antibiotics prescribed in the UK in a given 4-year period. At first sight, that's welcome news. The data shows that this decrease hasn't had a negative impact on patients with common infections like pneumonia, but we simply don't know yet if it's made any impression on rates of antibiotic resistance. Other data shows that GPs have reduced the amount of antibiotics they prescribe by 13% over this period. Dentists have also reduced their prescriptions by an impressive 20%, but the figure for hospitals is much lower. So it's not an equally distributed decrease, so the picture's more complicated than it may at first appear. Something else complicating the picture is a widely reported medical research paper published recently. This suggested that short courses of antibiotics work just as well to treat most bugs as the traditional longer courses of a week or so. Those conducting trials suggested that there's insufficient data to prove that short courses encourage antibiotic resistance, and argued that it's using antibiotics for longer than necessary which increases this risk. The newspapers ran away with the story, however, and sent out mixed messages by suggesting it was okay for patients to stop treatment once they started feeling better. So I'd urge caution. After all, an improvement in symptoms doesn't mean that the underlying problem has been resolved. Also, we can't recommend widespread change on the basis of one article in a medical journal. In any case, as the original authors were careful to stress, the suggestions aren't appropriate for all bacteria-based illnesses, and TB was the example they gave. Indeed, some bugs have proved especially resistant to antibiotic treatment, and the best known is probably MRSA. This came to light when, as a life-threatening condition for patients hospitalised for other reasons, it became particularly tough to treat. MRSA bacteria is notorious for being able to survive for long periods on surfaces like floors, taps, and even fabric. And of course, the fact that healthcare facilities are visited by huge numbers of people means the bacteria spread easily. But studies show that healthcare-associated MRSA declined by about 50% between 1997 and 2011, thanks to things like new guidelines and targets, as well as ward-based contact control and meticulous disinfection procedures. This shows us that rather than relying on one single action, introducing various initiatives on several fronts can limit the impact of the infection. Turning to other areas of concern, let's look at antibiotics in agriculture and livestock rearing. People might be surprised to learn that worldwide, the overall quantity of antibiotics used in food production is now higher than the amount consumed by humans. Something which horrifies me is that antibiotics are consumed by animals as a matter of course, simply to prevent problems, or indeed to speed up their growth. This happens a lot in intensive farming, where animals are kept in confined conditions. We've known for years now that this overuse is directly related to resistance in humans, so there's obviously an urgent need for farmers to cut down. So, is there any progress to report? Well, though there's still serious work to be done in places, for example, for manufacturers of antibiotics to stop discharging untreated waste products into watercourses and so on, it's not all doom and gloom. We're finding now that when doctors prescribe antibiotics, they're choosing narrow-spectrum ones. These are active only against specific bacteria and so cause less general resistance. And something which is being talked about excitedly in the pharmaceutical industry just now is a therapy which uses bacterial viruses called phages to treat infections, something which was first practiced about a century ago. Antibacterial therapies, whether phage or antibiotic-based, have advantages and disadvantages, and there's still a lot to be learned about the interactions between phage, bacteria, and human host. But maybe the time to take phage therapy seriously is rapidly approaching. Now, before I go on to the next thing.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a neurologist called Dr. Frank Madison giving a presentation about the overuse of painkillers. You now have 90 seconds to read questions 37 to 42.
I'm Dr. Frank Madison, and I'm a neurologist with a special interest in the overuse of painkillers, particularly of opioids, something experts are now calling the silent epidemic. Now, we've all seen the stereotypical images of addicts hooked on recreational drugs, but addiction to painkillers like opioids has a much less familiar public face. From what I've seen, one reason for this is that the range of people affected makes them less easy to pigeonhole. I mean, there's no typical age, social class, and so on. And of course, most people seeking help for opioid overuse were initially prescribed the medication by their own doctors for pain relief. This highlights a major part of the problem. Physicians often pay little attention to the possible risk of addiction. They need to look carefully at patients' personal histories and assess the risk, considering things like depression and anxiety disorders, before prescribing opioids. In recent years, there's been a dramatic increase in opioid prescriptions. I see a pattern not just of GPs overprescribing, but of GPs inappropriately prescribing. Sure, people want their pain relieved immediately, that's understandable. But proper pain management requires lengthy face-to-face input, which time pressures don't allow, so easier alternatives have become the default option. What's more, although opioids can provide effective relief in the short term, they shouldn't be the automatic first-line therapy. Many alternatives do exist, and they're no more costly. People generally think of pain as a direct symptom of a problem in the affected area, but pain is an extremely complex subject, and it's one that used to be underrepresented in medical education. Thankfully, that's no longer the case, and doctors now realize that when a patient complains of acute back pain, that pain may not be due to a clear and treatable disease, but that such pain often presents in people with other medical problems, and these need investigation. Although there are distinct types of physical pain, all too often I see sufferers lumped together in one category, which means that unfortunately not all treatments are going to work equally well. For example, we first need to know, is the pain caused by inflammation as opposed to nerve damage? Establishing this makes initial mistreatment far less likely, meaning that treatment is more effective and the risks of long-term problems are reduced. But it's not just opioids we need to watch. Patients often self-treat with readily available painkillers like paracetamol. And while such drugs play an essential role in pain management, people still need to know more about them. We've been pretty successful in publicizing the dangers of accidental overdose, and clear information's given about the effects of taking these drugs long-term, so public awareness about increased tolerance levels is also gradually improving. Many doctors also now actively warn patients about the spiral of taking higher and higher doses for pain relief. Worryingly, though, I've seen cases where people on drug regimes for other conditions inadvertently take painkillers which add a potentially hazardous ingredient to the mix already in their system. This is something which needs urgent attention. I'd like now to talk about an osteoarthritic patient who was referred to me, a 30-year-old woman, let's call her Anne, suffering from sarcoidosis, an autoimmune disease leading to chronic organ inflammation. She was prescribed various drugs, but though the disease was soon brought under control, the pain lingered, with Anne gradually becoming dependent on prescription opioids. Typically, she was terrified of stopping them, yet the more she took, the worse she felt. The thing is, her prescription would have been ideal for short-term pain, like that following surgery, but should never have been given for the chronic pain she was experiencing. And we all know that living with medication dependency has devastating consequences, not only on social well-being, but also on ability to function professionally, as was the case for Anne. She eventually went on long-term sick leave, as often happens in such cases. Thankfully, Anne's now much better, having recognized her dependence, and with the necessary support, tools and techniques, she's now off painkillers. The crucial thing is to prevent dependence in the first place. Anne's GP prescribed opioids in good faith, aiming at pain reduction, but failed to set an end date for these. He hadn't anticipated the possibility of eventual drug reliance, this being new territory to him. Anne couldn't hide the visible results of the quantities she was eventually taking, so her GP questioned her about intake. She reluctantly admitted supplementing her prescription from sources like friends and family, something her GP had suspected but hadn't investigated. Anne now realizes that drugs weren't fixing her problem, and though withdrawal took several tough months, her determination to succeed has paid dividends.
That is the end of Part C. You now have 2 minutes to check your answers.